everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I am a filmmaker and a writer and a few other things. But I've been working with CCF for over 10 years, over a decade, folks, creating all kinds of video content, live video series like the one you're going to watch today, patient-centric documentaries, treatment-based videos, event coverage, all kinds of videos. We have hundreds and hundreds of videos in our database, but all with the same mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we're here to do. This show specifically, the value I see is twofold. One, the information you're going to get from our guest today, and two, the shared experiences, the shared stories, and the support from the community that we've helped grow here at the foundation and here at the show. So if you're part of that community and you're a regular and you're here every week, you probably already know the drill. You might be saying hello and telling people where you're signing on from in the world. And if you are new to this journey, to this show, to the foundation, I want to say hello and welcome. And I encourage you to reach out to those also in attendance today and embrace that community. Introduce yourself. They will embrace you back. I promise you. Can't tell you how many times information that has been shared among patients has been key in helping people with their journey with this disease. So say hello. It's a very strong, supportive community, and you will be happy that you are here. So before we get started, we want to thank our sponsor, Ipsen Biopharmaceuticals. Without their support, the program wouldn't be possible. And we always have this disclaimer from them. And then that is that the opinions expressed today by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information that will be provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guests today and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. So that last line is really the takeaway. We're going to give you some good answers to your questions, hopefully today, and some good general advice, but by no means do we or our guests know your specific case. So take those answers, take that general advice back to your home team, which does, and make the best plan and path forward for you, because over the past 10 years, if there's anything I've learned, it's that each case of this disease is unique, and therefore each plan and path forward is as well. All right. Let's get to the show. Today, I'm very excited to welcome back to the show a veteran who's been on the earlier iterations of Luncheon with the Experts and the current iteration of Luncheon with the Experts. We love to have him here, Dr. Xavier Keutgen. How are you, Dr. Keutgen?
I'm great. How are you, Rain?
I'm doing well. Welcome back, my friend. It's good to see you. I appreciate you spending some time with us again. For those that may not have seen your earlier episodes, might not be familiar with your work, tell the folks at home a little bit about yourself and the role you fill in this neuroendocrine tumor community.
Sure. So first of all, I'm very happy to be here. Thank you very much for inviting me back. It's always a pleasure to be here with you. So I am a neuroendocrine tumor surgeon. I work at the University of Chicago, and I've been doing this now since 2013. My specialty, as I said, is surgery, and specifically what I look to do is not just to take out primary tumors, but also my specialty is in debulking livers or removing multiple liver lesions when the tumor has spread. Another passion of mine is research. So I do both clinical research, but also laboratory research. And specifically, I look in the lab on how I can radiosensitize neuroendocrine tumors and hopefully make therapies like PRRT work better.
Well, I think we're going to get a lot of questions today, as we often do every week, but we do with your shows specifically, because we always get questions about surgery and some of the research that you've alluded to already. So, folks, here's the deal. Go ahead and start sending in your questions. Dr. Keutgen is an awesome guest. Like I said, I've had him on the show a couple of times. That is for a reason. So you're going to have a really beneficial, great show today. So go ahead and start sending in those questions. We're going to do our best to get to them all. Listen, inevitably we can't, because we get hundreds of questions. That's why we have the show every week. So if we don't get to your question, just follow up with CCF, either here on the Facebook page. You can send them a private message or reach them at carcinoid.org, their website. And I promise you, we'll try to get that information. If Dr. Keutgen refers to something today, a study, a drug, a link, anything like that, we're going to do our best to, on the back end, include those in the comments section, so you don't necessarily have to go open a Google browser window and search for it. What was the name again that he said? Like, we'll try to do all that hard work for you. That's our job. But if not, like I said, if you have a follow-up question, reach out to CCF. If there's someone that needs to be here, our numbers are looking good so far, but if there's someone that you don't see that's usually here, tag them in the comments, let them know the show's going on. If there's someone who's been struggling with a surgical question or something like that, and you think today's show specifically would help, tag them in the comments, share the video, let them know what's going on. And last question, or last ask for you, if you see a comment or a question in the sidebar that you also have, or you're also interested in the answer to, just under the comment, you can like it, love it, any of the emotions that Facebook allows you to use. They all work the same way for me, and that's to upvote that question. Now, I'll see if 8 people have that question. I know that's one in high demand. Therefore, I'll make sure I get it across. Sound good? All right, let's go. I see a lot of questions coming in already, but Dr. Keutgen, I wanted to talk to you a little bit about your work with von Hippel-Lindau. I know this is VHL Awareness Month, and
Right.
can we let the folks just set a little bit of foundation of what that is, what that means, your work that you do in that space?
Yeah, sure. So essentially, von Hippel-Lindau is a genetically transmissible disease. It's quite rare. It's autosomal dominant transmissible, so meaning 50% chance if one of the parents have that, one of the children will have it. And it presents with a variety of tumors, including pancreatic neuroendocrine tumors.
Okay.
The most common thing is actually CNS, so central nervous system hemangioblastomas, which are benign tumors, but they can cause some problems because they grow in the brain. Renal cell cancer is another one. But about roughly 17 to 20% of patients with VHL will develop a pancreatic neuroendocrine tumor. And similar to another disease, that is hereditary transmissible called MEN1, or multiple endocrine neoplasia type 1. These tumors that develop in the pancreas tend to be a little less aggressive and generally more slow growing than sporadic or PNETs that essentially occur in patients that don't have these genetic syndromes. The general treatment for VHL-related pancreatic neuroendocrine tumors are that we let them basically alone. So we just basically observe them without surgical removal unless they reach roughly 3 centimeters, which is then we get to the point where we know the likelihood is that they're going to spread either to lymph nodes or to the liver, and so we would surgically intervene. And again, remember, it's different than sporadic or non-hereditary pancreatic neuroendocrine tumors, for the simple reason that these patients can keep developing these tumors throughout their entire life, because every cell in their body has this VHL mutation, meaning every cell in the pancreas has the VHL mutation, meaning every cell in the pancreas has the potential to develop a pancreatic neuroendocrine tumor. So the reason why we're less aggressive at taking these tumors out is that we don't want to chop away at the pancreas over and over and over again, and then they end up without any pancreas. So really, we observe these tumors in most cases. We're not overly aggressive, and we're essentially just removing them when they reach greater than 3 centimeters. And even then, we try to usually shell them out versus removing a big or large part of the pancreas, because again, you don't want to remove 80% of the pancreas. So you're left with 20, and then 10 years later, they develop two new tumors, and then we have to remove the rest of the pancreas, and then they're brittle diabetics. So those are sort of the general concepts on how we would treat pancreatic neuroendocrine tumors in VHL. And even MEN1, the size difference is a little different. So MEN1 tumors, which is, as I said, also syndromic, we usually let them grow to 2 or 2.5 centimeters before we would intervene surgically.
Got it. Thank you so much. That was helpful. We've got a lot of questions coming in already, so I'm going to go ahead and start taking some of those.
Sure.
First, a couple of people from North Carolina today. So I always want to give a shout out to those neighbors of mine since I'm in North Carolina. Ursula from South Africa. Hey, Ursula. And Lilia from Mexico. Welcome everybody else that I didn't get the chance to mention. First question from Gene. Do you or can you debulk abdominal or pelvic cavities that are popcorn ceiling like?
I'm not sure what popcorn ceiling like means, but I'm assuming they're referring to peritoneal carcinomatosis. So these are tumor deposits on the lining of the abdomen. And yes, you can debulk them. As a matter of fact, especially if you have larger tumors that are settled there, it's definitely helpful to remove the lining. It's called a peritonectomy because small bowel, and in general, large bowel either, but mostly small bowel, is in free motion in the abdomen. It constantly moves around as you digest food, and they can get caught up to this peritoneal nodule or this peritoneal disease, and that can cause blockages, strictures, cramping, and problems related to that. There's also some more and more awareness that when patients get PRRT, which is this radiolabeled therapy, Lutathera is the brand name, it can cause inflammation and maybe even more inflammation in those small peritoneal nodules, which again can cause some blockages and problems with the small bowel. So if you have peritoneal disease, depending on obviously the extent of the disease, but yes, you can most of the time remove it, and it may be worth it, especially if you have larger tumors.
Got it. Thank you. Yeah, popcorn ceiling is just a textured ceiling. Used to be popular a few decades ago. It literally looks like popcorn is stuck to the ceiling. So I think people use that as like a general term to refer.
I guess I'm too young. I've never seen it.
Maybe might be something here in the States. Yeah, but it's something now that everybody tries to scrape off. Most of it has asbestos in it, so it's always a mess to have to deal with. But I don't know. For some reason, some decades ago, they thought it looked good.
Yeah, and I mean, to that point, I think that peritoneal linings can be stripped, no questions. We never remove 100% of the tumors, so these operations are not curative. They are debulking operations, right? So I think that is important to make sure that our viewers and listeners get the concept that by removing this, we won't remove every single tumor cell, but yes, most of the time we can do that. And actually here at the University of Chicago, we work with I work with one of the surgeon who specializes in that for other types of cancer. And so these cases we usually do together, where he strips the peritoneum and I take care of the liver, the small bowel, the lymph nodes, etc.
Got it. Thank you.
So big case, but definitely feasible.
Understood. Okay, next question from Alan. If you have Y90 embolization, can you still do PRRT?
Great question. It comes down to what we like to refer as cumulative radiotoxicity. So what that means is essentially any therapy you have as a neuroendocrine tumor patient for metastatic disease has its plus and its cons, right? So anything we do has a potential side effect. That's just how it is in medicine. So for example, Y90 are radioactive beads that are shot in the liver to try to control the tumor burden or the tumor growth in the liver. And Y90, for liver disease, I'm not a huge fan of personally, because even though they can certainly shrink some of the tumors in the liver, they also have a really high radioactivity to them. And so there tends to be some additional radiation damage of the normal liver that is surrounding the tumors. And so some patients may even many years later, it usually doesn't happen within a year or two, but maybe 3, 4, 5 years later, develop some problems with their liver function and some fibrosis because they've had so much radiation to their liver because of the Y90. And then you have PRRT, which is a much lower radiation dose compared to Y90, but that goes everywhere in your body, right? So that's an infusion. It's a radioactive octreotide, essentially, is how you can think of it, that gets injected every other month for a total of 4 cycles, so a total of 8 months. And that goes everywhere in your body, including your liver. So the short answer to the question, can you add PRT to Y90 in terms of cumulative toxicity, meaning, how much radiation can your liver take, right? That's really the question. Is in general, the answer is yes to that. But I will say that it depends what shape your liver is into, right? So if there are certain overt signs that your liver has had some damage from the Y90, so if your liver appears cirrhotic on the scan, if you have ascites, so if you have fluid in your abdomen, or sometimes just a biopsy of a normal liver segment, for the pathologist to look at the liver and what it looks like under the microscope may be helpful in telling you how healthy your liver is. I think that is something that that certainly gives you more information in terms of whether you can get PRRT or not. But unless you've had, my experience generally, several rounds of Y90 and your liver is in really bad shape, PRRT may not be the best option. But most of the time, even though, again, I'm not a big fan of Y90, I think bland embo is a better option for neuroendocrine tumor patients personally, because it's not radiation beads, it's just general beads that just stop the blood supply to the tumor. I think most of the time you can get PRRT if you've had Y90 before. And you can even sometimes operate if you've had Y90 before, right? So if I can beat up the liver with an operation, usually it can sustain PRRT, unless it's already in really bad shape right now.
Got it. Thanks. And thanks for your question, Alan. Next question. This is interesting. I haven't heard this one before. Christy says, is it possible to tear muscles and or get a hernia along the Whipple incision line after months of recovery? Any thoughts on that?
Absolutely. Yeah. So anytime we open the abdomen, whether it's for Whipple or small bowel resection, liver debulking, a splenectomy, it doesn't matter. Every time we open the abdomen, we sew it back together, right? And a hernia, what we call an incisional hernia as surgeons, develops in the area, or can develop in the area where you have made that cut, right? And that can happen shortly after surgery. So let's say you have an infection, a really bad wound infection, then it never really heals nicely, and then things kind of fall apart and you develop this hernia. But most commonly it can happen many months or even years later. And that is usually due to the fact that for whatever reason, whether you're diabetic, whether you've had an infection, whether your immune system is compromised, whether you have been on certain drugs, whether you have really worked out a lot, or some of the stitches popped maybe right after surgery and you didn't realize it, so you have a lot of pressure. Obesity or weight gain, is another thing that puts a lot of strain on the incision. But all of these things can lead to the incision basically not healing properly and either popping open or slowly tearing open over time. And that can certainly happen even years after surgery.
Any thoughts on what she might do at this point?
Yeah, so it depends. Obviously, it's hard to say, right? I can't examine you. I don't know how big it is. Is it a small hernia, a big hernia? But generally with hernias, we say there's a couple of reasons why we would fix a hernia. Number one is if it's symptomatic, right? So if you have a lot of pain, pressure, it really hurts you, you're very uncomfortable. Number two, if you've had an obstruction, so if bowel gets trapped in it or stuck in it, and you need to go to the emergency room because you're throwing up and you're not passing any gas, that needs to be fixed. And then I would say a relative indication is like cosmetic reasons. Some people really don't like how it looks, or it bothers them because of, depending on where the hernia is with the pant line or the bra line. These are all things that can push somebody to have a hernia fixed. Generally, when we fix hernias with mesh, so mesh is a synthetic material that we put in to reinforce the abdominal wall. And depending on how big the hernia is, how many surgeries you've had before, it can be done either minimal invasively, so with a robot or like with a camera, or it needs to be done old school, sort of reopen the incision, put the hernia in, close the fascia, and then most of the time it heals really well.
Got it. Thank you very much. Thanks, Christy. Hopefully that helps. Let's see. Next question from Mary. Mary says, how do you determine when to operate as opposed to wait and see with a slow growing tumor?
Yeah. So generally well-differentiated neuroendocrine tumors are slow growing, right? So it's a good question. And generally, we like to say biology is king, right? So you can have the best surgeon, the best medical oncologist in the world. If your tumor ends up being an aggressive tumor, we have therapies, but ultimately the tumor will unrun the therapies most of the time, unfortunately. So by biology is king, we mean that usually the biology of the tumor, so how it is going to behave, is going to determine how you're going to do long term. Obviously, in addition to being seen by specialists, being in a multidisciplinary center, using the right therapy at the right time. These are all really important things. But sometimes, again, you can have the best medical oncologist or surgeon in the world. The tumor will like come back or will decide to grow despite the therapies that you use. So the way I approach this, and we approach it here at the University of Chicago, is generally if you present to me, let's say, with a small bowel neuroendocrine tumor that is spread to the liver, and it's a low-grade tumor like most of them are, we usually like to put you on the long-acting shots, so the octreotide, the lanreotide, the sandostatin, for 3 months, sometimes 6 months, and we see how things go. If the tumor hasn't grown, then clearly it seems to be a favorable biology, and I think at that point, as long as your liver tumor is removable and you're healthy, important to say that, right? If you're 90 years old, has had 3 heart attacks, you're not going to go to have a major operation. But if you're young, you feel good, you do well, or we expect you to do well after surgery, then we would push towards having an operation. When you have a pancreatic neuroendocrine tumors, which are those tumors that tend to perhaps be a little bit quicker in their growth, although not always, even more than small bowel neuroendocrine tumor, we would certainly want 3 months on the shots to make sure that things are stable. Occasionally with small bowel neuroendocrine tumors, we don't even wait the 3 months on the shots, but I think that getting an idea of the biology of the disease generally is a good tip to try to make us understand. Because let's say you have a pancreatic neuroendocrine tumor that has a lot of liver tumor, but it could still be debulked, right? But you go on the shots and within 3 months your tumor growth, then perhaps surgery is not the best option. Why? Because by the time I get in, I remove everything, you recover from the operation, some tumor may already be back by that time, right? So you really want to use the operation, the debulking surgery, when it gives you the most benefit. So maybe in a patient like that, giving them Keutgen, which is an oral chemotherapy, or even sometimes PRRT, if the tumor has grown on the shots after only 3 months, is a better option to try to hit the tumor hard enough that it's going to stay stable for a while, and then we can come in with an operation afterwards.
Got it. Thank you very much. Let's see. Next question, our friend Ursula from South Africa. If I have tumors, primary pancreas to liver and right ovary, I was told they were non-operable, had chemo that caused aggressive growth, then 6 rounds of PRRT that so far has given good shrinkage results. When are these tumors considered operable? Must they shrink to a specific size? And then when is liver embolization recommended?
That's a great question.
Okay.
So not surprisingly, your tumor responded to PRRT. The reason why I say not surprisingly is because we think that, or we know, at least from European data, that pancreatic neuroendocrine tumors tend to respond better with shrinkage to PRRT than small bowel neuroendocrine tumors. So what PRRT does to small bowel neuroendocrine tumors is sort of stabilizes them and doesn't let them grow for quite some time. With pancreas, though, roughly 50%, if you look at the European data, the tumor shrank. And a little side note is that that's exactly what I'm trying to research in my lab. I'm trying to figure out why pancreatic neuroendocrine tumors seem to be more radiosensitive than small bowel neuroendocrine tumors. And is there something I can learn from PNETs that I can then apply for small bowel nets to radiosensitize them, or lung nets, for example? So to answer your question, though, is there a certain size? So generally, no, but we want to have what we call liver tumor burden, meaning you take the liver and you look at how much tumor there is in the liver, right? So if you have greater than 50% of your liver that's replaced by tumor, generally surgery is not a good option. Why? Because we want to ideally achieve a certain debulking threshold. Some people say 70%, so you want to be able to remove at least 70% of the tumor. I generally tend to aim for 90%. So if I can remove 90% of the tumor, and that includes your ovary, that's usually not an issue. You just basically remove the ovary. So if I can remove 90% of your tumor in your abdomen, then I feel pretty confident that I've achieved a good operation that should have lasting results. So if I can only remove 10% of the tumor, that doesn't make any sense, right? So to if we go through a medical operation. So when you look at liver tumor burden, generally, I think the sweet spot in my personal experience is roughly 25%. So if you have more than 25% of a liver that's replaced by tumor, it gets a little bit more tricky to be able to reach that 90%. You could certainly reach 70%. And again, some studies have shown that that's beneficial still in terms of long-term survival. But if it's less than 25%, so if your tumors, and it's not the amount of tumors, right? Don't get that confused. I'm talking about liver tumor burden. So, you know, if a tumor looks like, has a volume of 1 gallon, let's say as an example, you would want, you know, less than half a gallon, or ideally even a quarter of a gallon of that being tumor, right? It doesn't matter how many tumors you have. I mean, I've removed 60 tumors out of a liver. You can do that. It's more about whether they're small tumors or big tumors. And if you take all these tumors together, how much tumor volume do you have? And then I would lastly add that you know, every patient is different in the localization of the tumors, where they are they larger, are they smaller, are they in relationship to some of the major vessels in the liver or the major bile ducts, you know, so it really is sort of an individual planning. But my take on this is generally that if you have any question about debulking, try to find an expert that does these cases, have them look at your scan, and they'll be able to let you know whether you're a debulking candidate. And again, important to mention, Rain, one more time, is that debulking surgery is not curative surgery. We're not, once the tumor has spread and it's metastatic disease, we're not, you know, removing every single cell here and the tumor will never come back. What studies have shown is that debulking surgery, number one, reset the time clock, so it puts you several years in the back where the tumor was much smaller, because you remove it physically, and so it may again take several years until it gets to that point. And then number two, it also has shown that perhaps certain therapies like PRRT may work better if you've had most of the larger tumor removed. So again, these are sort of things that we're still researching. We're still trying to figure out exactly where the role of debulking surgery lays with all these other modalities. But I think it's one of multiple modalities. And again, I can't emphasize enough the need for patients to get second or third opinion with neuroendocrine tumor specialists, multidisciplinary centers, where you know where they do a lot of these like tumors, a lot of these tumor surgeries, have a lot of experience to really understand, you know, whether your particular tumor would be a good tumor to have the debulking surgery for.
Got it. Thank you very much. Folks, if you joined us a little bit later, have just joined us recently, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. Today, we are here with Dr. Xavier Keutgen, and we are talking a lot about surgery predominantly, but other things as well. And it's going great. Great questions so far. Let's keep them up. Next one from Gwendolyn. Do you recommend any genetic testing beyond NGS panel for NETs, for NET patients, like testing for mismatch, repair deficiency mutation?
Yeah, these are great questions. So generally, so there's two ways to think about genetics and NETs. Okay, one way is to say, well, do we want to figure out whether your tumor is transmissible to your children? Okay, that's or you know, should your brother and sister be screened, for example, if you have a neuroendocrine tumor? And the vast majority of the time, the answer is these tumors are not genetically transmissible. We talked about a couple of rare syndromes like VHL or MEN1, so those are genetically transmissible diseases. They are usually not subtle, so usually you know it's been running in the family, multiple brain tumors, you know, neuroendocrine tumors, renal cell carcinomas, those type of things. So if you get a good family history and you don't have sort of a repeat paradigm or repeat pattern of multiple tumors that are the same one, it's rare, it's unlikely that you're going to have any genetically transmissible neuroendocrine tumor in your family. Okay. And so for that point, I would say, patient for the small bowel neuroendocrine tumor or even a PNET, that are in their 60s and 70s and have this tumor, they ask me, do I need genetic like testing to look for whether it's transmissible to my children? The short answer is most of the time you don't, because it's very rarely is. The other aspect of genetic testing for neuroendocrine tumor is to figure out what the tumor itself is made of in order to allow us to adjust or maybe improve our therapies for the tumors. So that is called precision medicine or targeted therapy. So that is sort of where medicine is essentially moving towards, not just for neuroendocrine tumors, but for all kinds of tumors like colon cancer, breast cancer, etc. So understanding what the tumor is made of from a genetic perspective encompasses multiple levels. You can look at just the DNA and look at whether you have mutation in the DNA. You can look at the RNA, which is downstream of the DNA. You can look at methylation assays, which is not a mutation in the gene itself, but it's regulators that shut off or on certain gene functions. So you can look at immune microenvironments, tumor burden, et cetera, et cetera. There's a lot of different things you can look at. And I would say that in general, the way we do it at the University of Chicago, because mutations in the tumor are very rare for small bowel neuroendocrine tumors, we generally don't use advanced mutational sequencing for small bowel neuroendocrine tumors, because we rarely get a hit that would make us think, oh, great, they have a mutation, let's say, in a gene that is commonly mutated in breast cancer, and there's a drug that's been developed for breast cancer, so let's use that drug to treat that small bowel neuroendocrine tumor because it has that particular mutation. Very rare in small bowel neuroendocrine tumors that would be the case. But for pancreatic neuroendocrine tumors, or sometimes for lung neuroendocrine tumors, there are some mutations that we can certainly find occasionally that are of interest for us to know, so that we could potentially adjust certain things for therapies down the line if therapy is needed. So that can include certainly DNA repair genes, which is what you have referred to. DNA sequencing and RNA sequencing is sort of standard for us here. But it does not necessarily have to involve methylation. I think that's pretty advanced. It's more sort of in the research realm right now. But yes, I mean, at the University of Chicago, if you have metastatic pancreatic neuroendocrine tumor, you will actually undergo, or once a tumor is biopsied or removed, that tumor specimen will be sent to sequencing. And also it allows us to, let's say you have an operation, we send it for sequencing, we know what your genetic profile is made of, right? And even though you would always go to the standard therapies like PRRT or octreotide, all these usual things, if the tumor at some point would really take up steam, so if it would grow a lot faster, we could biopsy that tumor at that point. Let's say it's 3-4 years down the line, and then we could compare it to the original mutational signature that it had and see, did it acquire the additional mutation? Is there something new that and usually there is, that usually the tumor is made of now that perhaps we could target. So I think it's helpful for peanuts. I hope that answered the question. I know it's a long answer, but it's pretty complex.
Yeah, absolutely. No, I appreciate it. And let me know if you have a follow-up question. Thanks, Gwendolyn. Earlier, Dr. Keutgen, you mentioned MEN1 or MEN1. Melinda has a question. Are you familiar with MEN4? And if so, let's talk about exactly what that is. And then the question is, any updates since it has been discovered?
So no recent updates, I don't think. So MEN4 is essentially this sort of a little bit elusive. So there's MEN1, 2A, 2B, and then those were sort of the standard multiple endocrine neoplasia platform, or like palette, so to speak, that people have described. Sure. They're all associated with specific mutations. So MEN1 is a mutation in the MEN1 tumor gene, and usually presents with like pituitary tumors, PNETs, hyperparathyroidism, and then MEN2A and 2B can be with hyperparathyroidism, medullary thyroid cancer. They can have mutation in the red proto-oncogene. So those are sort of pheochromocytomas is another one that can occur with MEN2A, MEN2B. But those are sort of the typical, very well defined and been defined for a long time, and like typical genotype phenotype correlation. So what I mean by that is you have a mutation and it expresses itself in a certain amount of disease processes, like pancreatic neuroendocrine tumor, thyroid cancer, hyperparathyroidism, etc. With MEN4, it's a mutation in a gene that has not like typically been associated with any disease sites, but that can, so it's not a mutation in the MEN1 gene, it's basically another gene, but it can act or can have some of the clinical features like MEN1 has. The reason why it's a little bit elusive is that it's something that is less robust on a science perspective to say if you have that mutation, you'll develop that tumor, like we know for MEN1 or MEN2A, for example. But it's definitely something that has been like correlated, where patients with these mutations definitely have been seen to develop these tumors. But not necessarily if you knock out this mutation in a mouse, they will develop these tumors. So that's what I'm trying to explain. So the scientific background, I think, is a little looser than with MEN1 and MEN2A and MEN2B. But to answer your question on whether there's been any new updates, I'm not aware of any significant new updates. I would say that generally the rules that we apply for the other MEN diseases should be applied there, depending on what the tumor is that you develop.
Got it. Thank you very much. Not sure if you'll have an answer for this one specifically, but a lot of people are interested and have been recently. Bethany says, any new word to providers from Novartis about the halt in PRRT production? Any knowledge on that?
Yeah, so I just heard this morning that we are resuming PRRT, I think July 13th. So, okay. So I think relatively soon, next 2 weeks. Yeah.
Good news. I know a lot of people
hopefully by mid-July, most places should be able to go back.
Great news. Great news. Do you deal with lung nets at all?
A little bit. Sure.
A little bit. All right. Let's take this one from Fred. What are some possible symptoms that a person may have from a lung net? And can an individual live with a lung net for years without treatment?
That's a great question. So, so lung nets generally don't produce symptoms. They are often incidentally found with a scan for something else. There are rare cases of lung neuroendocrine tumors producing serotonin and causing flushing and diarrhea, but it's honestly pretty rare. Now, if your lung net is sizable enough that it perhaps compresses a bronchi, so one of the windpipes, smaller windpipes in your lung, it can cause repeat pneumonia. It can cause repeat inflammation and infection in that particular segment of the lung. So that's rarely found, but you can definitely have that. Very even more rare would be that the tumor would be growing into part of this windpipe and cause hemoptysis. So that would be coughing of blood and things like that. It would be very rare. Can it be observed and not treated? So generally, I would say most lung neuroendocrine tumors should be removed for the simple reason that lung neuroendocrine tumors have a little bit of an unusual pathology in certain cases. So we can divide lung neuroendocrine tumors into what's called like typical lung neuroendocrine tumors, atypical lung neuroendocrine tumors, and then the really aggressive spectrum is the small cell neuroendocrine carcinoma, which is its own entity, but it is a neuroendocrine tumor. The atypical lung carcinoid or atypical lung neuroendocrine tumors can sometimes behave a little bit more aggressive than even sort of the intermediate grade pancreatic or small bowel neuroendocrine tumors. They don't always express somatostatin receptors, so they don't always pick up on the dotatate PET CT. And so there's sort of this entity where biologically, I talked to you about biology is king before, they're very difficult to predict in terms of how they're going to behave. And so generally, I would say if you have a lung neuroendocrine tumor, whether it's like typical and atypical, and sometimes, by the way, a biopsy is not enough to be able to tell that. Pathologists have to look at the entire tumor, which is a good argument to remove it. I would say you should probably have it removed.
Got it.
Now,
Thank you.
if it has already spread, that's a different story, right? So if you have
Sure.
stage 4 disease, the tumor has spread, then yes, it can sometimes be watched, especially if it's basically like a typical lung neuroendocrine tumor. And sometimes similar to small bowel neuroendocrine tumors, they don't grow fast at all. And so the usual therapies, especially if they express somatostatin receptor on the PET scan, can be applied there.
Got it. Thanks for your question, Fred. Next question from Gwendolyn. And we've been talking a lot lately about alpha PRRT. And so her question is simply, will alpha be safer for the liver than traditional PRRT?
Yeah, so traditional, take a step back. I think traditional PRRT is very safe for the liver. I've not seen any liver failure cases. I think that even though there are some reports that there could be some liver toxicity, I think this comes back to one of the first questions we talked about, cumulative liver toxicity, right? So if you've had external beam radiation or a lot of Y90 to your liver, or if you have, let's say you drink a lot and you have a cirrhotic liver that's already not in good shape, you know, then certainly PRRT can cause problems. But I think that in a healthy liver, I've not seen anybody get into major liver problems with PRRT as it is with basically beta-emitting PRRT. Alpha-emitting PRRT, the studies are being basically conducted. I think some of them certainly are promising. The difference between beta and alpha is that beta emits a shorter, travels a little deeper, but emits a shorter amount of radiation. Alpha travels not as deep. They're bigger particles, high energy, but potentially could destroy more tumor, right? So that's sort of the thinking. But whether beta or alpha is going to be better, it's going to probably need a head-to-head comparison. And just out of something to think about is that there are radio tracers that emit both alpha and beta, or even alpha, beta, and gamma. So, so there are certain new research beyond alpha already that has started to look at, you know, could we even develop a radio tracer that emits alpha, beta, or alpha, beta, and gamma, or just alpha and gamma, or beta and gamma. So those are sort of physics questions, but they are things that are certainly in the process. So is it safer for the liver? I wouldn't say it's necessarily safer than beta, but I think we'll have to wait to see what the clinical trial results will show. And they are certainly underway right now, so we hopefully should know within the next year or two.
Got it. Thank you. Thanks, Gwendolyn. Next question from Mervisa. After debulking on liver and radioembolization, I still have progression before debulking and after, and I am without therapy. What is the best choice in treatment at this point?
Yeah, so again, difficult to really answer the question because I don't have your scan. I don't know the time frame between, you know, your surgery and you know, the Y90, whether you're on octreotide or not, whether your tumor even expresses somatostatin receptors. So I don't know if you have a positive dotatate PET scan. Sure. But I would argue if you do have a positive dotatate PET CT, I think PRRT is probably the next best way to go. If your primary neuroendocrine tumor is in the pancreas, you could try CAPE-10, which is chemotherapy by mouth. I think sometimes rebiopsying the tumor, if it has continued to grow in the liver, and do genetic testing on it, like we talked about before, or figuring out what the grade is helpful, because occasionally, if it's a higher grade tumor, chemotherapy through the IV, like FOLFOX, FOLFIRI, you know, if you have a high Ki-67 or a higher grade tumor, can be helpful. So I think there are many more therapies, but it just depends on what is the status of the tumor, how does it look on the PET scan, and what is the grade and the Ki-67.
Got it. Thanks. I've got another kind of specific question, but I think Tina needs some help, so I'm gonna ask it and see how you feel about it. Tina says, I had tumors removed from my liver and small intestine / colon 5 years ago. It's been back with multiple places in my liver, and we are just watching them with frequent CT scans.
Yeah.
All I know is that it's slower growing, but it seems I'm getting more places of concern frequently. And I'm getting concerned, and I'm not sure that my oncologist knows how to treat NETs. So this is kind of the crux of the question. Any advice at this point?
Sure. Well, I think the crux of the whole meeting here that we are having is to make sure that patients get the help they need. And I would say, don't be afraid to get a second opinion. Since COVID hit, a lot of institutions, we do, for example, offer virtual visits. So
Right.
even if you are not physically in Chicago, wherever you are, we could certainly arrange for virtual visits. So and plenty of centers do this, specialized net centers. I don't think your oncologist will ever be mad at you or offended, or at least they shouldn't be,
Right.
if you go to get a second or third opinion somewhere. And I even tell my patients that come to see me the first time around, if you have any questions or if there's any doubt, please feel free to get a second opinion, because I think it's important. It's your body, it's your health, it's your life. You want to make sure that you talk to someone that you trust and that you think knows what the best is for your tumor. And you can't tag it to the medical oncologist. NETs is a specialty. It's a subspecialty, really. Most medical oncologists don't see a large amount of them because it's a rare tumor. And so it's not their fault, and they're not to blame for this. But I would say, if you say that you're not sure that your oncologist knows that much about NETs, you could even reach out to him and ask him, hey, who would you recommend for a second opinion, or just do it on your own. I mean, there are plenty of places online. You could go at CCF, their Carcinoid Cancer Foundation website where you have the specialized NET centers, even in your area by state. They list the physicians. And so you could certainly reach out to them or through them. And then lastly, I would say, if, again, difficult to comment really on your case in particular, but if you've had debulking surgery or tumor removed out of your liver, your primary tumor is out, and you've had 4 or 5 years without any therapy, that's pretty good. I would want to, if you would come to see me, probably get a PET scan if you've had one recently and compare it to the one, let's say, from a year ago or 2 years ago, to see how does the biology look, how's the disease really progressing, is it truly growing or not, do you have any new sites of disease or not. And then the first thing to do is usually to put you on sandostatin or on lanreotide, which is the long-acting octreotide, because that has been shown in multiple studies to slow down tumor progression. So if you have a little bit of a tick, tumor is a little bit growing, then certainly you could go on that, and that's a shot once a month, and very few side effects, and thousands of patients take these, and you could certainly do very well with that for many years.
Got it. Thank you. Folks, we got about 10 minutes left, so we're going to keep moving forward and try to get to as many questions as possible. Dr. Keutgen, Debbie says, have you had experience with a thyroid primary without receptors and METs to neck, lymph nodes, and throat? And the question is, what treatment options are there other than CAPTEM or CAPTEM and Afinitor?
Yeah, so by thyroid nodule or primary tumor, since this is a neuroendocrine tumor forum, I assume that you talk about the only neuroendocrine tumor of the thyroid, which is a medullary thyroid cancer.
Okay.
So medullary thyroid cancer is a neuroendocrine tumor of the thyroid. And generally, they can or cannot have receptors, a little bit similar to the atypical lung carcinoid we talked about before. So some of them have somatostatin receptors and light up on a PET scan, some don't. Even those that light up, PRRT and octreotide, long-acting octreotide, is sort of in the research. You would assume it would work well, but we don't really know. There's still a lot of research to be done there. For those where the tumor does not light up, there are therapies absolutely for medullary thyroid cancer that are not chemotherapy. So first of all, if it is spread to the lymph nodes and you have medullary thyroid cancer, you should have surgery. You should have the thyroid removed. You should have the lymph node cleared out. It may not cure you of the disease, but it will at least prevent complication with your throat in the future if the tumor continues to grow. Sometimes these tumors can even grow into the trachea, into the windpipe. So you really want to get that done. Once the surgery is done, you could send your tumor for genetic testing. A lot of these a lot of these tumors have a RET mutation, and there are now drugs that specifically target that RET mutation. They're called RET. So RET is spelled R-E-T. Okay, they're called RET inhibitors. And so again, it comes down to finding an oncologist that is a specialist in medullary thyroid cancer, and that can treat you potentially with those newer medication that are targeted once a tumor has been removed, and if there's some tumor left behind.
Got it. Thank you very much. Next question from Len. Are all debulked tumors sent to labs for genetic sequencing?
Yeah, so I alluded to that a little bit before.
Mm-hmm.
So at the University of Chicago, we have what's called reflex sequencing. So that means that every tumor that goes to the pathology department that is metastatic and is a pancreatic neuroendocrine tumor gets genetic testing done automatically. Patients that come with metastatic pancreatic neuroendocrine tumor to us that maybe have had surgery before will ask for the specimens and will have that sequenced. So the genetic testing done that. I don't think that there's necessarily value in doing this for small bowel neuroendocrine tumors for the simple reason that, like I alluded before, they rarely have recurrent mutations that are targetable. But definitely for pancreatic neuroendocrine tumors, gastric or duodenal neuroendocrine tumors that have metastasized, colonic neuroendocrine tumors, or lung neuroendocrine tumors, I do think that if the tumor has spread, I think there's some value there in doing it.
Got it. Thank you, folks. We got time for just a few more from Karen. What blood test, if any, do you use on your patients? A few other people are interested in this too.
That's a great question. So, well, there's a bunch of blood tests out there. There are tests that are more generalized tests, like chromogranin A. You probably have all heard about this. It's a tumor marker that can be used for all neuroendocrine tumors that are well differentiated. It has some drawbacks. So if you're on a anti-reflux medication, especially PPI, proton pump inhibitors like Nexium, for example, you can have really high levels of chromogranin A that are falsely elevated. So it's a false positive results. So generally, I think the sensitivity and the specificity of chromogranin A is pretty low. So it's been sort of debated in the neuroendocrine tumor expert world who still uses it, whether we still should use it. I would say I'm less enthusiastic about it than I was before for chromogranin A. Now, some of these tumors secrete hormones, like small bowel neuroendocrine tumors can cause carcinoid syndrome, flushing, diarrhea, wheezing. Those are usually due to serotonin overproduction that can be checked in the urine with 5-HIA, in the blood with plasma 5-HIA or plasma serotonin, so blood serotonin levels. Those are helpful if your patient is symptomatic, no question, and helpful to check later on. And then there are sort of pancreatic neuroendocrine tumors that can rarely produce insulin, gastrin, which come with a whole bunch of somatostatin, VIP, which come with a whole bunch of symptoms as well. Those are obviously helpful to check if your patient has these symptoms. There are newer tests like the NET test that some people may have heard of, that some institutions are starting to use. That's sort of a genetic test to look at whether your tumor, there's still tumor cells floating around after you've had surgical resection, for example. I think that the data on that, let's put it this way, there's some encouraging data, I think, but personally, we don't use it yet at the University of Chicago because I'd like to see some more data to see that it get validated in a larger cohort, especially in the United States, and see whether it's really applicable. But I think that in general, like with any other tumors, any form of cancers, liquid biopsy or ways to detect things in your blood that are not just the hormones that these tumors secrete, but more related to the genes of free-floating tumor cells, is certainly a futuristic approach to think about this. And at some point we'll get there, I'm pretty sure.
Got it. Alan says, it sounds like you are a proponent of PRRT, but would you use tools like Afinitor, everolimus, or sunitinib before PRRT for a PNET?
I think it's a great question. So I think every single therapy has its advantages and its disadvantages, like I said before. When you have a PNET, you essentially are looking, and I'm talking about a metastatic PNET, you're looking at debulking surgery, you're looking at liver-directed therapy for tumors in the liver, like bland embolization and Y90. Again, I'll mention it one more time. I would advise to stay away from Y90 because you want to keep your liver healthy. You don't want to give it radiotoxicity and 3 or 4 years down the line have issues with that. And it's never been shown that Y90 is better than bland embo. Then you have CAPE-10, which is chemotherapy by mouth. That can work really well for pancreatic neuroendocrine tumors that have metastasized. I've seen dramatic shrinkages in patients that were not operable, be able to go to the operating room after they've done CAPE-10. We have the usual long-acting octreotide, right? And then we have PRRT, right? And then we have everolimus and sunitinib. So everolimus and sunitinib, it's both been approved by the FDA. They are targeted therapies. So one targets the mTOR pathway, the other one targets the VEGF or PDGFR pathway. And the studies have shown that compared to placebo, which means no drug at all, it gives you about a 7 to 9 month progression-free survival, meaning they randomized people that had metastatic disease to take sunitinib or take everolimus or not, or just have no therapy. And in general, it took 7 to 9 months longer in those that took the drug for the tumor to come back. So I don't think it's a huge benefit, 7 to 9 months. I mean, certainly it could be helpful, and certainly we use it occasionally, but I think that CAPE-10, PRRT, or octreotide are therapies that have shown to have better progression-free survivals, although it's important to say that none of these drugs have been compared head-to-head. So we don't have a trial comparing PRRT to sunitinib, for example.
Right.
But again, I don't think it's necessarily needed to do these trials. I think, again, it depends on a patient-dependent manner, you know, where you are. Have a good discussion with your oncologist about the side effects. That's another thing. Everolimus and sunitinib tend to have a little bit more side effects than PRRT or octreotide, for example. So I don't think that there's no role for them. I think that depending on how you go through the sequencing of treatment, there is a role at some point. Whether it's before or after PRRT, I think that depends on your individual situation, what you're willing to have in terms of side effects.
Got it. Real quick, one final question. What about the cabozantinib, the trial? Pat said her husband has PNETs with heavy liver tumor burden, and his specialist wants him to try that. Any thoughts on that treatment?
Sure. So we have that trial open here. So it's a multi kinase inhibitor. So similar to some of these targeted therapy we just talked about, everolimus, you know, it's just targets more receptors and a larger pathway. I would say that if you have metastatic PNET with large tumor burden, we would recommend it to University of Chicago if you haven't tried already to go on CAPE-10, because I think that has shown that about 30 to 40% of patients can have a dramatic tumor shrinkage. So you haven't had CAPE-10 yet, before you go on a clinical trial, you should probably do that. If you have had CAPE-10, then maybe PRRT, because remember, about almost 50% of patients with PNETs have tumor shrinkage if you have the receptors on a PET scan. And we sort of used the clinical trial for cabozantinib for patients that have not had a response to either one of these therapies.
Got it. Thank you very much. Folks, that is our show for today. Bethany says, CCF, love all that you provide and always great experts. Keutgen is great. Thanks for your expertise. I have to agree. Thank you so much for spending some more time with us, Dr. Keutgen.
It was fantastic to have you, Rain, as usual. A big shout out to you and the CCF for doing this. I think it's fantastic. And hi to everyone that's been on the Facebook Live. I hope to see you soon.
Thank you very much. We appreciate that. And thanks to you again, as always, at home for joining us. We hope the program helped answer some of your questions. I'll reiterate one more time, reach out to CCF either here on the Facebook page or at carcinoid.org if you have follow-up questions. And thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, this program wouldn't be possible. We are off next week, so we will be back on June 9th. My name is Rain Bennett. Thank you for watching. I have been your host. Please join us next time, June 9th, for Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.